Hi guys, it's me again, your friendly neighborhood medical director, and I just wanted to take a second to discuss with you about geriatric trauma. The reason this is coming up is we've had several near misses lately regarding geriatric trauma, so I felt like it might be just a good opportunity to discuss some of the caveats related to geriatric trauma. So why do we care about this? Well, we care about this for a variety of reasons, but one of the reasons I care about this is because old people want your license. They want to take it away from you. They want you to become unlicensed. Their whole game, their whole goal is to take your license away. And that doesn't matter if it's trauma or shortness of breath or belly pain. I tell the residents this all the time. You can't trust an old person no matter how sweet they are because they are hiding pathology and they are going to get you. So what I want to do is talk about some ways that they're going to try to get you, some of their tactics and techniques, some of the things that they're going to try to do in the octagon to take your license away from you so I can help you hang on to your license. And by the way, hang on to mine. So medications. Medications are a big deal in trauma, and the reason for that is people tend to take medicines that affect things like heart rate, blood pressure, their ability to compensate for shock, or sometimes their ability to demonstrate shock. So if I take enough beta blocker, for example, I may not mount a tachycardic response. If, however, let's say I take blood pressure medicine, then maybe you've got a difficult time knowing what is hypotensive, and you'll see that we're actually going to make some recommendations here in a little bit about when to be worried about the blood pressure in an elderly trauma patient. Other medications that people take may cause tachycardia. They may blunt tachycardia. They may cause dry mouth. They may do any number of things. So it's always useful when possible to try to get a medication history from your patient so you understand how their physiology may be blunted or attenuated or accentuated depending on what they're taking. So older people are more likely to have comorbid conditions. So of course that can lead to an intolerance of just otherwise benign injuries. So if somebody has rib fractures but they also have COPD, then that's going to be problematic. If they already are on oxygen and then they break the ribs, that can cause a problem, right? Or maybe somebody already has heart disease and they can't tolerate very much tachycardia. Or maybe somebody has a pulmonary contusion and that's enough to really mess with their already baseline hypoxemia. Lots of different problems here. But additionally, sometimes this stuff can hide injuries because somebody may be already on oxygen, so we don't recognize that they are relatively hypoxemic, and so we may not be looking for their pneumothorax or their pulmonary contusion. But definitely these comorbid things can confuse the diagnosis. They can confuse what you're seeing in front of you and just make it less straightforward to make an appropriate diagnosis. Sometimes we run into humans that are somewhat bionic, right? They've got fake joints. Let me tell you a thing or two about fake joints. Fake joints really like to be dislocated during trauma. Dislocations can certainly lead to vascular compromise. Fake joints are a great place to get a fracture. So you can get a thing called a periprosthetic fracture where you fracture right around, for example, this post here on this hip replacement. Let's say somebody has a pacemaker or an LVAD or any number of things that become damaged during trauma. So then now we are left having to deal with this underlying physiology that we had been mechanically correcting, and now we have to correct that while also caring for the trauma that the patient undergoes. So really be on the lookout for people that have implanted devices, prosthetics, whether those are internal or external or any other kind of bionic issues. We like to talk about blood thinners. When we talk about blood thinners, of course, we're talking about things that are anticoagulants. And so people right now tend to be on Xarelto and Eliquis. Those definitely are going to make them more likely to bleed. Even aspirin can do this to an extent. Don't forget about the other medicines such as Plavix. We see quite a bit of these things. A patient with a head injury on a blood thinner is at much increased risk over somebody who's not. Elderly patients with head injuries are at risk anyway, but then you throw a blood thinner on top of that, and it can be bad news bears. Additionally, things like, I'm bleeding inside my belly might make it harder for me to tamponade, or if I have a open book pelvis that's bleeding, or even a big hematoma, which is relatively superficial. If I take blood thinners, those things can become very problematic. So this slide here is designed to remind you a little bit about some differences in the primary survey with the elderly person. Just make sure that you're cognizant of airway changes related to the elderly. Keep in mind, when you're looking at their C-spine, they may have limitation of motion. It may be difficult to assess. If you have to manage the airway, it may cause some difficulty. Dentition changes, remember, leave the dentures in while you're bagging, but take them out to intubate. Keep in mind, the elderly may have less hypoxic reserve, so definitely make sure we're giving them oxygen early, monitor their CO2, make sure we're maintaining ventilatory support. And like I said before, somebody with even just a couple of rib fractures that's elderly and maybe even has underlying pulmonary pathology is going to get themselves in trouble. Atypical vital signs are going to be the rule in the elderly folks, especially because of medicines which may blunt our response. We may mask volume loss, shock identification. So what I want you to think about is if they're hypotensive, if they're less than 110, I want you to think about them as being hypotensive. And then, like I told you a second ago, if they take anticoagulants, they're at big time risk for head injury. Dementia certainly is going to make it difficult to assess mental status, but let's go ahead and assume anybody with a GCS less than 15 has had their bell rung, right? Keep in mind, people may have eye surgeries, they may have had their lenses replaced, any number of things that may alter your GCS. And then keep in mind also that we need to really keep these patients warm. They're going to not have as good temperature regulation as a younger patient, and we all know that if we get people cold in trauma, that leads to problems. Finally, skin breakdown is a real problem in the elderly, so we want to get them off the backboard as soon as we can. We also know that the backboard inhibits respiration, so again, the little grand lady who can't breathe well at baseline, when you strap her to the backboard, you're really going to cause some trouble for her. So get off the backboard as soon as possible. Remember, backboards are extrication tools, but not necessarily immobilization tools. We know from lots of experience, lots of evidence-based medicine, that elderly patients who are badly injured do much better at a trauma center, and that's whether we start out there or not. They do better once they get there. But we know that patients who don't make their way to the trauma center have increased morbidity and mortality. So the point to that is, if you have a patient who is severely injured, it probably makes sense to bypass the community hospital. You go straight on to the trauma center. Okay, there's lots of papers out there. Just do a quick PubMed search if you want to see some. This paper that I have up on the screen right here was created here in Oklahoma by several people in the area. So let's talk about the silver trauma. So this is trauma in patients greater than 65. This comes from Great Britain. So some mechanism to think about: if they fall down the stairs, if they fall from any height other than standing, or they fall from standing and they just look terribly injured, like their face is broken, they're altered, they have belly or chest pain to palpation. Any of those things should get your attention. But I really want you to think about mechanism, and I want you to think about physiology. So systolic blood pressure less than 110, heart rate greater than 90, GCS less than 15. Those should all get your attention. 2 or more body regions, so chest and pelvis, for example, chest and belly. Or if you think they have head or spinal injuries as a result of their trauma, then consider upgrading them to priority 1. And then be on the lookout, like we talked about before. Occult shock can be hidden by medicines, or maybe exacerbated by pre-existing cardiovascular disease. If you think they have spinal injury, then those things usually don't happen in isolation in the elderly. Also think about coexisting medical conditions. Do an EKG on these folks. I think if you've been doing this for any period of time and have any level of experience, you've seen people who have had STEMIs that cause them to crash their car as opposed to the other way around. So really keep an eye on those things, and then don't fall prey to satisfaction of search, which means you find an injury and you quit looking. Make sure you do a good head-to-toe exam to look for any and all injuries that they may have. So in conclusion, just think about these geriatric trauma patients as being so much different than the other trauma patients that you deal with. Have a higher threshold for taking them to the trauma center, and I think a good rule of thumb is if they are injured enough or have a high enough mechanism of injury you feel like you need to take them somewhere, lights and sirens, then that somewhere should probably be the trauma center. As always, thanks for your attention, and please contact me with any questions.